Now, let's learn a little bit more about case tracking or counting your cases in synesthesia. Well, before we get into that, let's answer a question. Why do we need to keep track of this information? Well, it turns out this is a requirement from the COA. Who is the COA? The COA is the Council on Accreditation, and this is the accrediting body that accredits all CRNA programs throughout the United States. And these are standards that have to be followed. So let's look at this. When you get on the COA's website and you look under accreditation, they will have the guidelines for counting clinical experiences. So let's look at this document. So to highlight a few things, okay, you can only take credit for a case where you personally provide anesthesia for critical portions of the case. You may only count a procedure that you actually perform or do. You cannot take credit for an anesthetic if you are not personally involved with the management of the anesthetic or if you observe someone else providing care. Two learners should not be assigned to the same case unless it will provide an opportunity for both students. And typically, this is when two anesthesia providers are necessary due to the acuity of the case. I'll give you an example for that. A trauma, where you've got one person who is continuously running the mass transfusion device, one person staying organized, and then one or two other people giving different medications. That would be a time where it would be appropriate to have two students in a case. Additionally, you need to, as the student, consider experiences that provide value versus experiences that might lack value. The goal and focus should be learning experiences that provide educational value. So if you're at a clinical site, it's very common for you to occasionally give breaks or lunches where you're not involved in a demanding part of the case, right? This is more of an observation role. And if you were to give 3 lunches, all right, in a day, you probably would not count those 3 cases unless you were there for induction, emergency, demanding role. Now, at times, you may count that. Say something develops and you end up staying, or say it's a very complex case. That might be a situation where you can count that. However, by far and large, giving a break or lunch, you should not count that case. If you were to go in and start a case, perform the induction, and then leave, you would only count the intubation. Okay, you did not stay for that case. So let's look at the very specific guidelines for counting your clinical experiences. Of note in synesthesia, you have a clinical time and then you have an anesthesia time or anesthesia hours. The reason we do this is the definition here. Clinical hours include time spent in the actual administration of anesthesia. This is the anesthesia time. The total clinical hours are inclusive of the anesthesia time. Therefore, it has to be at least equal, but more than likely greater. So if you were to do a 24-hour in-house call shift, say you're just covering OB, and it was the luckiest of days. You didn't get to do anything anesthesia related. You didn't even go start an IV. All right. That would be oh so rare, but that would be 24 hours of clinical time, but 0 hours of anesthesia time. You have to keep track of the physical status or the ASA score. Okay. You have to keep track of class 1s, class 2s, class 3s, 4s, 5s, and 6s, along with emergencies. Note the numbers that are bold. Those are the absolute minimum. The numbers to the right of that are the recommended. However, you will be expected to get the most that you possibly can out of your clinical time. It is very common for a student to well surpass the recommended because your time in the clinical setting is going to reflect your ability to come out, practice, and provide anesthesia. A couple things to clarify here. The initial pre-anesthetic assessment. This is whenever you're going to go in and perform a focused anesthesia assessment. This is not a comprehensive history and physical. This is a focused anesthesia assessment. Okay. The post-anesthetic assessment. Okay. This is where you would go over anything that occurred in the intraoperative or postoperative period. So an example of this, say you're assigned to PACU, you're working with an anesthesiologist or CRNA, and you go to assess someone's pain, their fluids, their vitals. Say that patient's hurting, and the PACU nurse asks you, what do you think this patient should have? Or I've reached my limit of pain medication orders. So you go back to your supervising provider and you say, this patient's uncomfortable. I think we should do another milligram of Dilaudid. Okay, that would be a post-anesthetic assessment where you are actually managing, you are taking into account that patient's care and working at assessing their status. That would be a post-anesthetic assessment. Now, the comprehensive history and physical. This is not a pre-anesthetic assessment. Okay, so at times, as the anesthesia provider, you will be required to complete a comprehensive history and physical. This is not something that is often done in the PAT clinic. This is going to be a comprehensive history and physical, okay, where you're going to look at not only the H&P, but a psychological assessment, pathological changes, psychosocial variations, evaluations of all the body functions, and this will include using inspection, palpation, percussion, auscultation, and any other advanced techniques. All right. You're not going to be completing 10 of these a day. You need to keep track of your special cases. Anybody who is over 65 need a minimum of 100, recommended 200. Pediatrics, 2 to 12 years of age, at least 30, recommended 75. Less than 2 years of age, at least 10, recommended at least 25. And neonatal, at least, all right, at least there is no minimum. However, they recommend at least 5 cases so you can handle those very neonatal, those very immature airways. Trauma or emergency cases, you need a minimum of 30, but recommended 50. So an emergency case is whenever there is urgency or a continued threat to the patient's well-being. There are fewer resources available during the regular operating time, and there's limited assessment and planning. When a case is deemed an emergency based on the professional opinion of the operating practitioner, the case may be counted as an emergency. Okay, so an emergency case. All right, newly diagnosed kidney stone, patients rapidly becoming septic. They're not NPO. You do an RSI. This is an emergency. All right, not an emergency case. That add-on hip fracture from 36 hours ago. Patient's been NPO. Someone did a pre-anesthetic assessment yesterday, and the surgeon adds it on simply because they don't want to do it tomorrow. So what's an emergency versus what's not an emergency? Obstetrical management. So this is making sure that you have experience in managing all of OB anesthesia. So total of A and B, minimum of 30, recommended 40. You have C-sections and you have analgesia for labor. So at minimum, 10 C-sections, ideally 15. Hopefully you're going to do at least double that. Okay. Then you have your analgesia for labor. Okay. This could be an epidural. This could be, so some examples from it, an epidural, a redose. All right. So say you put in an epidural. This would be analgesia for labor. This would be a pain management encounter. This would be a regional technique, a pain management technique. And then you have your pain management. If you only perform one intervention, all right, you would not count it as a case, but the actual skill. So say you just put in the epidural, you're not going to count it as a complete anesthetic. So doing a combined spinal epidural, you would count the spinal and epidural because you are puncturing the dura, you're getting into the intrathecal space. And here's the pain management encounters. All right. Pain management can include a number of things. Beginning or starting an epidural or providing an intrathecal, say you're doing a labor spinal. Beginning a PCA, performing a regional block, administering specific pain medications to a patient specifically, all right? In acute pain, perhaps in PACU, if you were to perform any pain management like trigger point injections or nerve stimulation. So that are just some examples of the pain management encounters. The anatomical categories, you're going to keep track of intra-abdominal, intracranial, oropharyngeal, intrathoracic, neck, neuroskeletal, and vascular. So intra-abdominal, anytime you enter the abdominal cavity, whether this is open or laparoscopic. Intracranial, open. So an open procedure like an open craniotomy or a closed, okay, say an intracranial procedure. A good one is an aneurysm coiling. That would be a closed intracranial procedure. Oropharyngeal procedures. Anytime you're entering the mouth or oral cavity for a surgical case. All right. Bronchoscopy. All right. A FES, endoscopic sinus surgery, anything like that. Intrathoracic, where this could be a VATS, this could be a number of things. You need at least 5 open heart cases. You can do those with or without bypass, ideally 10, and then closed heart cases. So this could be a cardiac ablation, a transcatheter valve replacement. All right, this would not be a cardiac cath or a routine pacemaker. VATS or lungs, so video assisted thoracic surgery. You need a minimum of 5. And then you have this other category, a mediastinoscopy, a number of other procedures that don't really fall in well but are intrathoracic. Neck procedures, tracheostomies, are a great example of a neck procedure. Neuroskeletal and vascular. So aortic stents, that's a good example of a vascular type case. You're going to perform a minimum of 400 general anesthetics, probably hundreds more than that. Now note the induction with minimal or no assistance. This is not going to be something you're doing as a brand new SRNA. This is going to be as you have spent months in the clinical setting and you handle the entirety of the induction. Now, this may be with your CRNA or physician anesthesiologist standing right there, supervising you directly. However, This is an opportunity for you to show that you could safely induce this patient without intervention. Inhalational induction, mainly with peds, at least 25. Mask management, okay? So a mask case, right? A good example is BTTs, tympanoplasty, and tube placement. Supraglottic airway devices like LMAs, a minimum of 35, at least 50. You're probably going to do many more than that. At least 250 intubations. And this could be oral, this could be nasal, endoscopic techniques. So alternative tracheal intubation techniques using a McGrath, all right, transtracheal jet ventilation, cricothyrotomy, actual tube placement, all right, simulated tube placement, and this is all under endoscopic, and airway assessment. Those are some various airway techniques. Now note we have the other techniques, okay? Light wand, bougie usage, anything like that. And finally, you have emergence from anesthesia. At least 300 times will you be waking somebody up. You have regional techniques as well, where you're going to keep track of your spinals, your epidurals, your nerve blocks. You'll have your actual administration. So you will keep track of all of your regional anesthetic techniques. Your spinals, minimum of 10, ideally 50. Epidurals, minimum of 10, ideally 50. Nerve blocks, minimum of 10, ideally 50. Now, one thing I want to point out, say you're on blocks and you're going to be doing a nerve block for a total knee. You're going to do an adductor and maybe you're going to do an IPAC. You can actually count that as two different blocks. Or if you're blocking multiple nerves, that is two separate blocks. Monitored anesthesia care, at least 25, but hopefully 50, all right, deep sedation cases where you don't have an airway. All right, you don't have an invasive airway. You may have an oral airway, but in that case would not have an LMA or an endotracheal tube. And finally, at least 25 arterial punctures / catheter insertions and 30 times using it. At least 10 central lines. And then this CDP monitoring, at least 15. This can be with a Visualeo, a flow track, anything like that. And ideally 5 Swan-Ganz catheters. So other clinical experiences, ultrasound guided techniques, regional, vascular access, point of care ultrasound. We want to keep track of point of care ultrasound. So anytime you were to scan somebody, say to assess whether or not they have a pneumothorax, say you're doing a focused assessment, all right, that would be an example of using point of care ultrasound. Assessment of chest x-ray. This is where you're going to recognize normal and abnormal findings, evaluate proper positioning of lines. Say you put in a central line. When you assess that chest x-ray afterwards, it's not simply viewing it in the patient's chart. It's actually reading it. You should have some practice with this as well. So now let's look at how we're going to chart some of these cases. I'm going to go to case tracking. We're going to clock in and out. We're going to add some cases. All right. Let's do that Da Vinci. Let's do that. Let's do a Da Vinci hiatal hernia. All right. If you do multiple cases, say 5 colonoscopies, you can easily chart however many you did. So we're going to say we did 3 Da Vinci hiatal hernias. One was an ASA 1, one ASA 3, one ASA 4. Okay. Patient assessment. All right. I did 3 initial pre-anesthetic assessments, 3 post-anesthetic assessments. I didn't do a comprehensive history and physical. I had one patient that was over the age of 65. No trauma or emergencies. Anatomical categories. This was 3 intra-abdominal. For methods of anesthesia, I did 3 general anesthetics with minimal assistance. Tracheal intubation, 3 oral intubations. And these were 3 IV inductions. Say I performed McGrath on 1 patient, okay? So I did an actual tracheal tube endoscopic placement. I woke all 3 patients up. And in that 65-year-old, let's say I put in an art line and we monitored it. Click add. Click save. And this is how it's going to look. My 3 Da Vinci hiatal hernias in each category, the methods of anesthesia, arterial technique. Oh, I forgot to chart something else. I started in IV. I'll go to anesthesia procedures only. I'll go to other. I started 1 IV. And very easy, it will track your case requirements. Say you did a case that is not on there. Say you did something very specific. Oh, let's say you did a BESS with stealth and dura repair. Okay, so we got into the dura, doing a functional endoscopic sinus surgery. I can easily create that procedure. I can categorize it. Okay, so we're going to go with ear, nose, and throat and create it. And I can easily add that case. Say it was ASA 3. Same thing. My pre-anesthetic assessment, my post-anesthetic assessment. They were over 65. All right. We're going to say oropharyngeal since we started in the nose. And since it was a dura repair, we're going to say a closed intracranial. This was a general anesthetic. And a regular intubation. My emergence. And that's it. And so you can see where this procedure shows right now. When you clock out for the day, you would put your actual anesthesia time and it would keep track of it. And you can easily see everything you did for that day. So that's a high-level overview of clinical case tracking, your clock in and out time, your cases, procedures, and additional COA requirements. Hopefully that helps explain things. If you have any questions, please let me know. Thank you.